Welcome, everyone. I want to welcome you all to our program today. Today's program will be the last one for 2024. Please make sure to visit our website, macularhope.org, for upcoming programs for the 2025 season. We'd like to thank Regeneron, Apellis, Sun Pharma, AbbVie, Macular Health, and Notel Vision for their support of these programs. Macular Degeneration Association was founded in 2007 by Lawrence Hofheimer, who is our chairman of the board. His mom had developed macular degeneration, and at the time that disease wasn't in, they did not have a name for that disease. They considered it old age. They considered when people lost their vision, that was just part of the aging process. He watched his mom lose a good portion of her vision. She was no longer able to read, do the crafts that she wanted to do, recognize people's faces, and this upset him, and there was no information. They would go constantly to the doctors to try to get new eyeglasses to help. We have come a long, long way in the development of this disease with the new treatments. So we're looking forward to Dr. Lowe's presentation. After the presentation, there is a button on the bottom that says Q&A. Please put all your questions in that box there. Do not raise your hand because we will not see that and your question will not be answered. I'd like to tell you a little bit about Dr. Pamela Lowe. Dr. Pamela Lowe is an OD. She is currently the director and the president of the Professional Eye Care Center Incorporated, a private practice she founded in 1992 on Chicago's Northwest Side. She received her Bachelor of Science degree from Lowe University of Chicago in 1984, graduated with honors from the Illinois College of Optometry in 1988. The college named her Alumnus of the Year 2002. She has been a career-long member of the American Optometric Association and currently serves as chair of the association Strategic Communications Committee, as well as key person for the American Optometric Association Advocacy, and is past chair of the AOA Contact Lens and Cornea Section. Dr. Lowe is a fellow with the American Academy of Optometry and a diplomat of the American Board of Optometry. She has lectured and authored on many topics, including retinal disease, cataract extraction, laser vision correction, and travels throughout the country, speaking on new technologies for early detection of macular degeneration, dry eye disease strategy, and myopia, myopia management. I'd like to welcome Dr. Lowe at this time. Dr. Lowe, it's your floor.
Well, thank you, Andrea and Donna. I'm just so happy to be here. The Macular Degeneration Association is just a wonderful organization, and most organizations that do so well like they do and are so helpful to my patients started with, a personal experience. And so to hear how the founder's mother, lost vision and he had to watch her go through that. And we know of all of our senses, the one we would hate to lose if we had to lose one of the five senses would be our vision. So I love this topic. I recently wrote an article about this topic because when we talk about vision loss, there's a lot of angst that goes with that and a lot of fear, right? So I want to talk about the good news about how we can preserve vision, and knowing exactly the mechanism of macular degeneration is really important, because then you can understand why, as your eye physicians, we want to teach you strategies that are really all about lifestyle that can help stay off, especially if you're at high risk for the condition. So let's dive right into the good news about macular degeneration. Here you can see, I just always like to say my disclosures. And so I've been practicing for 36 years. So I consult or speak for these companies that you see here. And I do that because they have excellent products that help my patients. So let's talk a little bit about our objectives today. And really, the goal of the lecture is to have you leave after this hour with really understanding more, not only about what macular degeneration is, but really the strategies to maintain eye health as we age. What does that look like? What can we be doing? There's probably things that we would come to top of mind right off the bat, but I hope I could shed some light on things that may not be as apparent to you. And it's really important to understand the connection through how we move our body and what we put into our body really is key, not only for our general health, but for our long-term vision as well. And then when we're specifically talking about macular degeneration, what can we do to decrease our risk? Because we don't want, if we're at high risk for it, we don't want to go on to that end stage of macular degeneration. And it really is a huge burden on the healthcare system. And we're going to look at the numbers now, because if you look at all the eye diseases, macular degeneration is really the big behemoth in the room. So look at today's prevalence. And I've been doing these lectures for a number of years now. And so it's amazing how the prevalence has just gone up. Right now, there's just under 20 million Americans that are 40 and older that are living with the condition. And almost 1.5 million of those are living with vision-threatening macular degeneration. So there's a whole lot of folks that have early signs of macular degeneration. And once especially we identify that, how can we avoid from going on to that 1.5 million that actually start getting vision loss that affects their life? And look at it compared to other conditions in my world that could be sight-threatening for my patients. Diabetic retinopathy, that's a huge one. Diabetes does put you at higher risk for macular degeneration. And over 9.5 million Americans living with diabetes, and close to 2 million where that diabetes is really affecting and threatening their vision. And then glaucoma, that's the one we always hear of. But when you look at glaucoma, 3 million Americans approximately, and that we call that disease the silent thief of sight because there's no early symptoms. So unless a patient knows their risk factors and it's being seen regularly, half of them don't even know they have it. So unlike macular degeneration, that takes away your central vision in patients once they get to the advanced stages, they know that right away. Glaucoma actually takes away your peripheral vision and can lead to total vision loss. So those are the big ones that we think of, but look at, you add up those at risk for vision loss from glaucoma and diabetic retinopathy, and it doesn't even equal the prevalence of macular degeneration. So it's really, really important from a public health standpoint and individually for each patient that we know what our risk factors are. And I like to show you this. These are images of the retina. You can see here on the left side of the slide. That's what a normal, what we call fundus should look like. This is the optic nerve, carries all the blood vessels that nourish the retina. And everyone, when I put these images up for my patients, they're like, what's that little dark spot area there? Because it looks like it shouldn't be there. That's what a healthy macula looks like. That's where all the light comes to a pinpoint focus for our best vision. And we want to keep that structure healthy. But sadly, up to not too long ago, almost 80% of patients present with already irreversible vision loss when they're first diagnosed with the disease. And a good chunk of those, just under 40% of those, are already legally blind in at least one eye. So there is this gap in diagnosis because it's not, if we're looking at the old way we used to diagnose macular degeneration, it was by the patient coming in and saying they had vision loss. And then we start seeing these structure changes. So here, instead of that dark central crisp macular area, you could see we start seeing these white areas. We call that drusen. They're actually cholesterol plaques that build up, and they break down the photoreceptors in our macula and our central vision, and that's what can lead to vision loss. And then, of course, this is what early or dry looks like, and we don't want any of these late stages happening because that's where patients get significant vision loss. So there's been this big gap in diagnosis. So as eye doctors, we're like, well, what can we do to be better. If we're waiting for the patient to either tell us because they lost vision, or if we're looking at structure changes, now the macular degeneration train has already left the station, and we want to do better than that. So key is for us to educate patients and ourselves on what the risk factors of macular degeneration are. And you can see there's multiple risk factors here. The 4 on the left, we cannot control or change because family history, our genetic roll of the dice, we can't change that. We fortunately, if we're lucky enough, we get older each year, right? And we can't change that. We can't change the gender we were born because females actually get macular degeneration at a higher rate than males. And we can't change the fact if we go on to get cardiovascular disease because we may have a genetic predilection for that. And diabetes is right in there as a systemic condition. But the ones on the right put us at great risk. Smoking puts us at 5 times greater risk, especially if we have family members that may have had macular degeneration. Now you're really putting more on what those genetic roll of the dice gave you. And now that lifestyle of smoking can really accelerate the process. If we are over our normal body weight or have poor nutrition, that puts us at higher risk. And we're going to talk a lot about if we have the macular pigment, the pigment that protects our macula and our central fovea where we see the best. If that's low, that puts us at higher risk. So let's talk about a little bit about genetic testing, because all of medicine is starting to go to more customized, individualized treatment. And knowing your genes, that genetic roll of the dice, like I like to refer it to, is very important for me as the eye doctor managing my patient to know what risks am I dealing with and how often should I be seeing the patient. So genetic tests now have really been something that we turn to. I know in our practice, we like to turn to that to just know exactly if the patient has a lot of other risk factors, what we're dealing with genetically. So when we look at genetic testing, it's important not to only take a DNA sample and see if the genes for macular degeneration are there, but also matching that up with what we call your phenotype. What environmental factors play into it? You know, are you a smoker? What's your body, mass index? A lot of UV light exposure, all those play into what your genes give you. So there definitely are genes that we have that we can inherit that put us at greater risk for getting this disease. And if you look at the chart here and at this bottom line here that just says the general population, and this is age in years, and then the risk of getting macular degeneration is on the vertical axis here. So if we do not even have a family history that we know of, in the general population, about 10% of people can go on to vision loss from macular degeneration just simply by aging. Each decade of our life that goes by, the risk gets greater. But if we have a family history, now that bumps up, accountable for 70% of the reason we may go on to get macular degeneration. The other 30% would be what our lifestyle and environment that we're putting ourselves in. So when we compare that, the genetic risk of getting macular degeneration compared to all the other diseases that, have a genetic predilection, you can see here, diabetes is a big one, right? That's 26%. Obesity, that definitely is an inherited trait. That's over 50%, but the cardiovascular disease, prostate cancer, and breast cancers. So those all have a certain percentage of genetic risk, but macular degeneration really, really is the one that tops the chart with that. So if you have a family history that you know of, sometimes, I have patients report, I'm like, hey, any family history of eye diseases? And they're like, well, I had an uncle who went blind, but no one knew why. So it is important if you can nail down that genetic link. It's very, very important, because if there is a genetic link, there's certain variants to your genes that are coupled with your risk of getting macular degeneration. So if we just look at this example, we have a father and a mother, right? and they have, they might have inherited a 50% neutral risk of getting macular degeneration and then 50% risk. So if you just look at when they have offspring, there's a 25% chance that the mom and the dad gave the low risk or neutral genes to the child. And so there's a low genetic risk of getting macular degeneration. But there's also a 25% chance that they did get both the high risk gene from both parents, that they are at a greater risk of macular degeneration. And then you could see 50% is, might be neutral in there. So it is important for many of my patients who especially are diabetic, who especially have cardiovascular disease, or have had excessive UV light exposure, or definitely are smokers, that I know as their doctor where they fall, because then I can better manage them and know how to track them. And so that's what the genetic testing can do for us. So if I look at a patient, it's very important to know, especially if they're overweight, have UV exposure, smoking, and they don't move their body a lot, because we'll talk about how just moderate exercise can reduce risk. It's very important I know this larger 70% piece of what their genetic roll of the dice was. So again, that can be very important to manage. It can give a lot of patients ease of mind, because if they do have a family history of it, and they might be stressing if they're at high risk, and they may be at low risk or moderate risk, and that's good news for them, right? And I even tell patients, even if you're high risk, the good news is we know you're high risk, and now we could take measures to make that better, because this has been a game changer in macular degeneration and bridging that gap of those folks who weren't diagnosed until they presented with vision loss, or I, as the doctor, saw structure changes. So this has been a big paradigm shift this last decade in how we detect and manage macular degeneration. And only timely comprehensive eye exams with doctors who have this technology, you'll be able to know right away if you are at even greater risk, because this tells us the earliest biomarker for macular degeneration. So let's dive a little bit into the science behind what dark adaptation testing is. And basically what we're testing is when you go from, normal illumination, like let's say you're at a movie theater and you're in the lobby, and then you go into the dark theater, right? We've all had that little, moment of where we're like, oh, this is dark in here, and we may walk a little bit slower until our eyes adapt. Well, that is the earliest change that happens in the very beginning of macular degeneration, before a patient has one letter of vision loss, or I see a structure change as their doctor examining them. Poor dark adaptation, a lag time in how quickly we dark adapt, is the first symptom that can happen. So again, so awesome that we have a technology that really could let us know before early changes if something's happened. So just quickly, this is one of the classifications traditionally as doctors, the Beckman classification that we've used to see what bucket our patient is and what their risks are. So this is on examination. If they don't have any drusen, those waste product buildups, those cholesterol buildups, where we see no pigment changes in their central vision, then we say, okay, you're good. You don't have macular degeneration. Then if patients start getting these little drusen changes on the retina, they're of a certain size, they're small, and again, we see no changes directly in the macula itself with the pigment that is one of the layers that protects the macula and helps us see our best, then that's called early macular degeneration. And then as those drusen get larger or more numerous, or we start seeing any pigment changes in the central macula, we call that intermediate. And then what we don't want the patient to go on to is any advanced form. And geographic atrophy is the dry advanced form. Think of it like a cookie cutter. The area just atrophies away and tissue is taken away, and that's what causes vision loss, or the wet or neovascular macular degeneration. That's the one where both of these now, we used to say wet was the only one that had injections as a treatment, but now for geographic atrophy or dry, we also have injection. So good that we have those if patients do go on to advanced, but our goal is to not go on to advanced or slow that progression as much as we can. So this is what night vision looks like when someone darks adapt for a patient that doesn't have macular degeneration. You can see that's what normal night vision looks like. Subclinical or early macular degeneration, this is what it looks like. But there is another condition called cataracts. That's very common. Everyone has heard that word. That's where the lens of the eye that sits well in front of the macula, behind the colored part of our eye, the iris, the lens of the eye, can also have us be symptomatic at night. So it's really important. Is this just kind of normal night changes with glare that a patient might report, or is it actually really impaired because of macular degeneration? So we always have to have good science behind anything that we present for a patient, especially testing. So this is what was so great and turned my head when I learned about this and got this technology into our practice right away when I learned about this. So they took this was a study that took 325 adults who had no clinically detectable macular degeneration. They were, these doctors knew these patients were part of the study. We were looking really hard for any structure or function changes. So they were adults without clinically detectable macular degeneration. And at baseline, about 24% of the subjects exhibited an impaired dark adaptation. Again, no structure or vision loss. And then they followed them up for 3 years. And amazingly, at a very high rate, those folks that had impaired dark adaptation, where there was a lag time with how they went from light to dark, that clinically significantly, they went on to get macular degeneration. The study had to stop after 3 years because of funding. So, there could have been the small percentage that didn't convert in 3 years, probably would have if we have studied those. So very powerful that this was not a test that said, oh, you're at risk for macular degeneration. It actually, if you were positive, it took over 6.5 minutes for you to dark adapt. We know now that we have a new part of our classification. So instead of no AMD to early AMD, now we have subclinical macular degeneration. So if they have impaired dark adaptation, that is a biomarker for the disease, not a risk factor. We know that, again, I like to give that reference, the macular degeneration train has left the station, and it's our job as patient and doctor to slow that train down. So now, instead of saying, oh, patient doesn't have any macular degeneration, and then we'll see you in a year, now we take subclinical, early, intermediate, that all equals macular degeneration, and we better start seeing the patient more often and educating them on what they can do to slow the disease. So again, the clinical sign is you will test positive and have delayed dark adaptation, and that symptom will be decreased night vision. So what is the first thing? We ask everyone 50 and older in our practice, have you noticed any changes in the dark? And again, a lot of times patients will say, yeah, with these headlights, I get glare and flare, and it's been bothersome. But, we actually tease it down and say, but have you noticed it's harder in dark situations? And then if they say yes, or if they have a family history of macular degeneration or just want to know, we are running dark adaptation testing, because it is actually used to be a desktop unit where we would have a special dedicated room that was dark. It had to be super dark in there. We even had to turn off the computer, cover the lights on the phone, put a dark towel so no ambient light would get under the door. But now look at this. It's for the past few years, the technology has advanced so much where it's a headset with an onboard technician that actually walks you through the test. So you can see the patient here is doing the test on their own. Super simple, easy, and gives great information. And medically, when it's medically needed, it's medically billable as well. We run it as a screening test sometimes for patients who just want to know, but if we have a medical reason to run it, then that's a billable expense to their insurance, which is great for a patient. So let's talk a little bit about lifestyle risks now. So we know if you have a genetic predilection, we're going to definitely want to see you more regularly and watch things, but what are the things we can do in our lifestyle to make things better? So definitely, again, up to 5 times greater risk, especially depending if you have high risk genes, that smoking is just going to fuel the fire for going on to vision loss later. Obesity and poor diet. So we're going to talk a little bit about what a good diet looks like and exercise strategies. And then low macular pigment. That's called MPOD, and we'll get a little bit more into that. We can actually measure the pigment in your macula that protects it from aging and gives it better performance. So really cool, newer technology as well. And then you could see here, timely eye exams are so important to find out what your risks are if you have diabetes or cardiovascular disease. But these are all the things that we can be doing and talking about and devising a plan as patient doctor to really help stay off, any progression. So smoking. So, every smoker goes to any doctor and tells them to stop smoking. So they've heard it time and time again. But I think the message is a little different when we hear it, that it could also affect your vision, because smokers, they smoke, they've been smoking probably a long time, and they're like, oh, I'm fine. I got to die of something. I've heard all those things. But when you tell someone, what about your quality of life? What about if you lost your vision? And like you said, you're doing well physically and you can walk around, but what if you couldn't see anymore? So that does make patients take pause. I literally had a patient who was being treated for stage 4 lung cancer. And believe it or not, I'm taking the history. So as I'm talking to her, I said, so I assume she was actually part of a study here at Northwestern University for a new drug that was out at the time. I said, so I assume, of course, you quit smoking, because I knew she had a history of smoking. She's like, oh, no. And I'm like, you have not quit smoking? And she said, well, no, the doctors say I'm doing amazingly well and to keep doing what I'm doing. So I'm still smoking. Crazy, right? But when I told her you could lose your vision, you're putting yourself at such a high risk, because she had an aunt who had macular degeneration, that did make her take pause. I did find out she cut down on smoking, but still a smoker. But it's hard to do, and we don't take that lightly. Some folks can stop smoking cold turkey. That's great if they can do it. Most can't. That's super hard. There's psychological referrals we can give where the patient can have hypnosis or emotional therapy. And then, of course, in the pharmacology world, there's dermal patches, there's the gums, capsules you can take. But it's very, very important, especially if we're going to turn to a medication or tobacco patches, things like that, that we coordinate that with primary care doctors. What I love, there's actually apps on our phone now that can help a patient. It's more the psychological aspect. It'll tell a patient actually like, how much money they're saving if they cut down or quit smoking, how many years they're putting on their life. So it's really great feedback for patients. But this is one that we really feel compelled to tell our patients about, because it's really something that many patients haven't heard about, especially new patients to our practice. We find they really have no idea what carotenoids, or your macular pigment optical density, that's what we refer to as MPOD, what that is and why it's important to know where they fall in the spectrum for their long-term macular health. So carotenoids are pigments in nature that protect. So, the red, orange, yellow, all the hues on fruits, the bark on trees, those are all pigments that play an important role in plant health. And carotenoids are a way we can eat a lot of the different things in our diet that can put those into our system. And there's about 40 to 50 carotenoids found in our human diet, the things that we normally eat. So if there's about 50 in our diet, and then we ingest those, about 20 of those carotenoids stay in our blood, but there's only 2 that go to the brain and the eye, and that's lutein and zeaxanthin. So a lot of us have heard about lutein, but a lot of us have maybe heard about zeaxanthin or not, and it's always, seems like a hard word to spell, that zea thing. But zeaxanthin and lutein are the only 2 carotenoids or pigments in nature that we consume that go to the eye, and they're in our macula, and they also have been found in the brain. So that eye-brain connection, think about it. your eye, your optic nerve, is a direct continuation off of the 10 nerves that come off our brain. And so super important that these carotenoids are not only in our eye and protect the macula, but also in our brain. So let's look in particular at the macula. So if you look at the macula as a whole, again, this is the cornea, light goes through there. This is the iris or pupil. This is the lens of the eye we talked about where we get cataracts. And then all the light, if it's getting to our macula like it should, hits our macula. And our macula is a certain area on the retina. In our whole macula itself, there's a 2-to-1 ratio. I'm sorry, there's a 1-to-1 ratio of lutein and zeaxanthin. So if you look at the macula as a whole, it's 50-50 lutein and zeaxanthin. But if you look at the fovea, the very center, our color or cone, our cone receptors, which are our color contrast receptors, it's a 2-to-1 ratio of zeaxanthin to lutein. So it's important to kind of know that, because when I prescribe for a patient and go over what they're eating, then I can target and prescribe what amounts I want them to have. So macular pigment, or your MPOD, that lutein and zeaxanthin, contributes to protecting your macular pigment. Macular pigment, the pigment in our macula that our body creates, and this is like a spectron, a magnified view of the 10 layers of the retina. This dip is our macula. And so it protects us from UV light and all the harmful blue light that's in our world now. And we're going to talk a little bit more about how blue light is more of a thing. We've all heard of UV light, and UV light is in the blue light spectrum. So if you look here, of the spectrum of light, the cool or blue is our UV. And then as the nanometers of wavelength of light get higher, then we have the blue light that we've heard of, computers, cell phone, tablets. There's some that comes from the sun as well. And we need blue light. Blue light helps our mood. That's why, here in Chicago, when it gets, winter and we have those days of gloom, there's that whole kind of depression thing because we're not getting that light that makes our mood up. But these are all the things that are naturally, we can't take these out of our world. They're all part of our world. But it is important to know that they do affect our macular pigment. So think of your macular pigment, or MPOD, macular pigment optical density, as the sunglass for your macula. And if that is low, which we'll find out it's low on many of us, that's another risk factor for macular degeneration. Again, we want healthy MPOD to protect our macular structure and function. And we know if we have a healthy amount of macular pigment that our visual performance is better. But look at these numbers. Almost 80% of us have macular pigment less than 50%. That's huge, right? That's, a big chunk of the population that now is at risk for going on to macular degeneration. But the good news is you can achieve, by taking supplements with zeaxanthin and lutein in them, we can achieve a higher MPOD. And this is actually a chart we like to show in our office. So if you look at this chart, this is the MPOD score, which we can measure with a quick, easy test. And then this is, let me go back. And then this is, if you have no pigment, then 100% of that harmful light is going to get to your macula. So you can see how the scores correlate to how much blue light are reaching, that harmful blue light that's reaching your photoreceptors and can take away vision. If you're 50% and above, and again, the higher you are, you could see that's a less of a risk of that harmful blue light affecting you. So we tell patients, what's your MPOD score? We actually measure that. And so that's important not only for macular degeneration risk, but visual acuity, how we perceive things. We're going to have better contrast sensitivity. We could see things better with contrast, especially in lower light situations. And we're able to perform activities better if the higher our contrast sensitivity is. It also helps people with low MPOD tend to be really light sensitive because they don't have that protection. And so they'll find more glare. And it's really it's hard for them to recover if bright lights go in their eyes. So your macular pigment plays a big role, not only in reducing your risk of macular degeneration, but your visual performance. This is the unit, and we still have this in our office because we've got this actually 17 years ago. We've been measuring pigment for a long time, kind of the gold standard. It's an instrument that we measure. The patient just puts their eye in, pretty quick and easy. And it's based on, it's called heterochromic flicker photometry. So it's just a way that we can measure how much pigment you have. So we won't get in the weeds of that, but the really good news is now it's a handheld unit that's really easy, much easier and quicker instead of taking you in another room and measuring it with a special instrument. So we can get results right in the exam lane chair, which is really great because, again, that's another big risk factor for going on to get macular degeneration. And we want to be on top of where the patient's pigment level is. So we said we can supplement to get that pigment level up. And we all know, everyone's heard of AREDS, and that acronym stands for Age-Related Eye Disease Study. And I just wanted to give you a little background, a quick background on the AREDS study, because the first study was multi-centered. It was amazing, a very large group of patients. And these studies are so expensive to do that we won't see a lot of these studies again. But the original one was from 1992 to 1988. Patients either had no macular degeneration to advanced. Those were the criteria for letting you in the study. The average age was about 69. Their diets varied, but almost 70% did take Centrum at the time, which was a supplement, just a multivitamin. And we found from that study great information that we knew, hey, if we took certain vitamins, we could reduce the risk of going on to advanced macular degeneration by 25%. And this was the original formula you see here: vitamin C, vitamin E, beta carotene, which is vitamin A, zinc, and copper. And then they repeated the study again in 2006. And some of the original folks were part of the study. But to be entered in the study, and this time you had to have intermediate macular degeneration in one eye was the minimum requirement. The average age was older, 74. These patients had diets that were high in carotenoids and vegetables. So we'll talk about lutein and zeaxanthin, where those can be found, which are spinach, kale, Brussels sprouts, broccoli, the peppers of color, all those things. So these patients did have a little healthier diet. Almost 90% took Centrum Silver, which was an advanced multivitamin over the original Centrum. So, and then we found that by adding lutein and zeaxanthin, the carotenoids that weren't in the original vitamin, that it was actually more beneficial for the patient and help reduce the risk of going, if you had intermediate, of going on to advanced. And also they added omega-3s, which, the kind of healthy oils, fish oil, that can be very beneficial as well. They took the beta carotene, the vitamin A, out because if patients were smokers, vitamin A increases your risk of lung cancer. So those studies were great, right? But the last one, the results of that was 2012. So there's been a lot of information out there now that lets us know that, hey, you know what? There's other things we could be adding to a supplement for our patient that really, really can be helpful. And we can see here, vitamin D helps, not only studies are showing helps with glaucoma, with pressure control, but we know it's a powerful anti-inflammatory. And we know when COVID hit, for our immune system, and vitamin D is key. So really plays a role in macular degeneration, and also uveitis, which is inflammations we can get in the front or back of the eye. So vitamin D, can't say enough about that. All our diabetic patients are on that. We're here in Chicago, so anyone who lives above the 30th parallel, we're not out soaking up the sun as much as those of us who live below the 30th parallel, where naturally we're getting more sun, because that's the main way we get vitamin D, is through that. We can get it through our diet, but it's just a small amount. We found that B6, vitamin B6, really helps with visual processing. And it also, in combination with folic acid and B12, really is a powerful antioxidant for macular degeneration, because when our macula ages and we get more of those structure changes, that's all localized inflammation to our macula. So if we can take anything that can help with inflammation, that helps the macular health as well. You can see here folic acid, which is actually B9. The homocysteine level, that's an amino acid that again contributes to inflammation. It has great properties to help with macular degeneration as well as CoQ10. CoQ10 also has a role in glaucoma and cataracts. So these are all vitamins you've heard of, and then in combination can be really, really great for prevention of macular degeneration or progression. Numerous studies since that 2012 last study with the AREDs that support intervention with carotenoids, specifically those lutein and zeaxanthin, along with those other vitamins in conjunction with that, really can play a big role, along with moderate exercise. There's studies that show just moving our body and walking as little as 4 city blocks a day for people with known vision changes in one eye from macular degeneration can reduce their risk 30 to 40% of that going on to the other eye. So when it comes to ocular nutrition, if we just solely look at the age-related eye disease studies, AREDS 1 and 2, those are just saying, well, yeah, it's good to supplement, especially with AREDS 2, only if you have intermediate to advanced. Well, now we know we don't have to wait till patients have changes, that there's benefits to supplements taking them before. So again, when I look at my patients, would I rather be on the proactive side or the reactive side? And we have good science to tell us being proactive is great. So who should supplement? In our office, we have frank discussions with patients. Hey, if you have a family history, whether you have structure or function loss, I'm highly recommending changes in diet, but also supplementing. If anyone low MPOD, low pigment, definitely. Someone tells me they have high exposure to UV light, they're out in the sun, they love to garden, they're outdoors all the time. We always recommend UV protection in glasses and hats, but we really want to be on top of it. We just watch it for our patients who still cannot quit smoking, that we don't give them any vitamin A. And of course, if we see structure changes for patients, we're going to want to put them on a vitamin right away if we're actually starting to see physical changes. And then we look at their genetics. So that's the macular risk assessment. And we look at where they fall, what genes are the highest risk for them. And then we love to prescribe according to that. So if we have retinal findings, if they're even not in your macula, but if you have drusen, those waste products, those cholesterol buildups, even in your peripheral retina, far from your macula, we're having the discussion because that puts a patient at higher risk for that eventually migrating to the macula. So those are folks that we're definitely have any structure changes or a big diagnosis with macular degeneration, we're going to target a vitamin for them. So that, begs the question of, when do I start talking about macular degeneration? Do I wait for patients like this who visibly look older? That's been a big paradigm shift in our office. So when is it time to talk about macular health? And we say now. We say with everyone, kids are growing up with cell phone, tablets, computers, and the youth have the greatest blue violet exposure. Kids in school have their Chromebooks, it's part of school. Then they want to come home and play on their digital devices. So we talk about it from the get-go with our patients and all families, especially because look at this. I know many of us on the call are in the high-risk age for macular degeneration, but all of us know younger folks or have family members, grandkids, and children that we really need to have these discussions about what blue light can do. And it's not going away, because look at this. When I heard this a few years back, this young man, Kyle, earned $3 million in a Fortnite World Cup game. Look at this. This is like a stadium of people watching people on a screen compete at a game. So my point is, God bless Kyle for making $3 million at 17 years old. Hopefully he puts that to good use. But it's there, and we need to start talking about it. This was just a few years back. I went to a block party that my brother invited us to, And it was wonderful. There's vendors all around. And then this was actually, there was a stage right to the side of these two young men with a band playing music and being interactive. But look, they're on their digital devices. So, it's just a matter of what we do. We're on digital devices watching this talk right now. So, everyone's heard about ultraviolet light protection, about coatings we can put on your glasses for blue violet protection. I urge you to have those discussions with your eye care provider, because there's different manufacturers, and I just put these on to show that there's a lot of choices, not only for sun protection, but also for blue violet light protection. So let's talk a little bit about the carotenoids, lutein and zeaxanthin, and taking those as supplement, what that can do to minimize our blue light, all the blue light that we're surrounding. And I will tell you, ultraviolet light has been super well studied. We know that your risk for getting macular degeneration is way greater for our folks who had a lot of UV light exposure. So our construction workers, people who just worked outside all the time and maybe didn't have good UV exposure. We know that can damage the structure. There's actually a condition called solar retinopathy. Everyone knows you have to have special glasses on if you look at an eclipse. We should not stare at the sun. So we know UV, that very low nanometer wavelength light, is very, very powerful at the structure. But to be honest, we don't know the long-term effects of this blue light hazard. So the one that's a little higher wavelength, we're not sure what it does to the structure, but we know it throws off the quality and quantity of sleep. And for all of us, that's important, but especially in kids, that is super important because their brain's still developing. So we don't want their quality or quantity of sleep to be affected. And blue violet light, remember, makes our brain think it's daytime. And again, there has been numerous studies that link symptoms to screen time, and that if you improve your nutrition with lutein and zeaxanthin, that it helps protect it and is better for a long-term outcome. And, this is really important to know. Excessive screen time, especially in kids, it is shown to have lower self-esteem. There's mental health issues. They get locked into that whole system. So their learning process, it could lead to cognitive decline. So really, really good science behind excessive screen time. So we instruct our families, please always limit. The younger the child is, the more we need to limit the screen time for them. But again, when we look at the good news, if we can increase our MPOD scores, higher MPOD has been correlated with cognition in adults and kids. And that lutein and zeaxanthin are actually essential for early neural development. So that's great. And other studies have shown of kids, this is a study for kids from 7 to 13 years old. They just, if they had a higher MPOD score, their intellectual capability, they scored better on standardized tests. And they just had better, functions in intellect. So it was really, really great. And then we know in a study that followed of 18 to 25-year-olds that this brain-derived neurotrophic factor, we call it BDNF, that helps with verbal and visual memory, that was all increased. So really, really powerful that these lutein and zeaxanthin that we can supplement with have no side effects basically, and can help with cognition. And so it really, really boosts. Remember, we said if they're the only two carotenoids that get to the macula of the eye and to the brain. So we know the benefits of these two carotenoids. Our ocular structure and our function is going to be better. So our visual performance, that blue violet light protection helps with our sleep. The MPOD is being protected when we build it up. And again, now we have science that's showing us that it could help preserve our cognition and really be beneficial in diseases like diabetes and cardiovascular disease. So I want to switch to now, that's what we put in, right? And I want that we could supplement with, but I want to really, the change that's gone over time in my 36 years of practicing has been unprecedented with obesity. So if you look at this, 2/3 of adults and 1/3 of children are struggling with being overweight. And if these rates stay the same, over half of us in just 6 short years of the population will be at obese levels. That's a big burden on the healthcare system, and we'll see why that scientifically can be an issue. And this is really key. If you look 20 years ago, no state had an obesity rate above 15%. Today, there's over 40 states with obesity rates over 25%. That's like just crazy. And we know that's all about how we're moving our body and what we put in. The rate of childhood obesity, I've seen it in our offices in adolescents, has almost tripled since the 80s. And that's when, I was just graduating high school. And look at these numbers in our age group, 70% of older men and almost 70%, over 70% of older men and almost 70% of older women are overweight or obese. So the numbers are just showing it. And, it's really about what we put in. The standard American diet, and that acronym for it is SAD, because it is sad, right, is just not where it should be. And you can look here, the Surgeon General's warning, our standard American diet causes approximately 2/3 of the deaths in America due to disease, because 95% of chronic disease is caused by inflammation from the foods that we eat and the lack of moving our body. And when we talk about moving our body, I'm not talking about running a marathon. We're just talking physical exercise. And, I put these images up in my talk that I give doctors and to patients, is because, this used to be TV, right? TVs used to be these big things that sat across the room, and sometimes you'd pull them closer. I know we'd go home for lunch and my mom would have the TV on to watch, whatever show when we were come home for lunch from school. But, that the glow of the TV used to be the thing. But now look on either side here, you have these video games and computers, and then kids are just right in their face. They have digital devices right there. And so we're not walking around when we use those devices, right? So our movement has just dramatically decreased. I said, we used to come home and we'd walk to school, and then we'd walk home for lunch, and then we'd walk back to school and walk home. Less than 10% of school-age children today walk or bike to school, compared to almost 50% back in the days when I was growing up in the 60s. Only, sadly, 4% of elementary schools and less than 10% of middle schools. In high schools, it gets even worse, provide daily physical education for students. It's just not built into the curriculum. 50% of US adults and 65% of adolescents don't get the amount of physical activity that's required. So a lot of it is just our world has changed and come inside with digital devices. And oh my God, COVID really did that to us. So when we talk about the science behind not moving your body, so if you have higher body fat percentage, the lutein and zeaxanthin you may take through your diet or supplement with stays in that adipose, that fatty tissue, and does not get out to the eye and the brain as readily. And so that's the rub. And that's one of the reasons, not only for cardiovascular health, right, and for risk of diabetes, that's one of the reasons we want to just keep our body mass index in a relatively good rate. So how should we move best? And again, I always tell patients, it's not running a marathon. It's just getting to the habit of doing something. So the recommendation is getting your heart rate up for 150 minutes a week. So 30 minutes, 5 times a week, whatever that looks like to you. And that could be either steady state, where you're just doing a walk at a certain pace. You can do intervals where you walk faster and then slower, or do your elliptical faster and slower for periods of time, or high intensity interval training. All of those are good depending on where you're at. High intensity interval training is more beneficial to cardiovascular health. But again, I tell patients, start where you are. And then it's important, cardiovascular is the most important, right? Get our body up moving. And what does getting your heart rate up mean? I say that's if I was talking to you on the phone and I could tell your voice wasn't steady, that's the definition of getting your heart rate up. Because there's all different numbers and formulas depending on age. But if I could tell that you're moving, that means your heart rate's going up. But resistance training, especially as we get older and especially for women, that's very important for our muscle tone, our balance, our bone density. So, those are the recommendations. So again, just really quickly here, you can do steady state where you do, up to 30 minutes, 5 times a week of constant moderate pace. Running, walking, brisk walking, whatever works for you. Or you could do equal cycles of 2 to 3 minutes of faster and then steady state, faster and steady state. High intensity interval training is where you do like 30 seconds of all out and then about 4 minutes of steady state. And then you do 4 to 6 cycles of, all out. And then that is more efficient at lowering blood pressure, helping cholesterol, than interval or steady state. So again, but I tell patients, do what can fit into your lifestyle. So resistance training, that should be about 2 to 3 days a week. When we say, well, how much weight do I do? Whatever muscle group you're working on, take whatever, like the maximum weight you can use. So if I'm doing a curl, let's say my maximum weight of just doing one is about 20 pounds. Then I cut that in approximately half to do my cycle. So if it's 20 pounds where it's my maximum I could do, then I'd cut that down to 10 pounds. And that's what I would do, where I would do 8 to 10 cycles of that. The repetition's important and doing cycles of it are important. And then, of course, you would adjust that weight if for age or if you had an injury. So if I had an arm injury or an elbow injury, and then 10 pounds was too much, I would bring that down. But the more you bring the weight down, that's fine, but just increase your repetitions. But I tell patients that's important. Resistance training is important for mobility, bone density, balance, but cardiovascular health is really the most important. So you want to get those habits done first. So again, what exercises constitute resistance training? Well, just doing squats. One of the things I love about the digital devices we use is I can download for free off of many sites. Instagram, like on my Instagram pop-up, it knows that I'm into exercise. It's amazing how these algorithms know our habits. But I can download free little exercises to do there. You'll see multi-joint exercises to me are great because you're just getting more muscle groups. And really the plank, just planking is just really great for our core and for balance. But all of these, as you can see, are great. I try to make a habit, even if I'm traveling, because I don't even need an exercise room to do it. If you could do 50 squats, a 50-second plank, 50 push-ups, and mine are always modified. I have to be on my knees for that. And then a 50-second wall squat. I mean, just those things, doing those every day, working that into your schedule, and you could do it anywhere. Again, it's just about building a routine. And then you could see single joint exercises would be like your leg and knee extensions, hip stuff, calf raises. Again, all these things you could do in your home. So it's really great. So just wanted to give you some resources for exercising. These are great resources. You can go to the National Institute on Aging, has great stuff, as along with the American Heart Association. The Center for Disease Control has a lot of information on there. You wouldn't I wouldn't think of that traditionally for that, but they're the Center of Disease Control and Prevention. So they have some good information there. And then there's free classes for anyone 65 and older called Silver Sneakers. So I thought that was great. One of the benefits of time going by, right? And I know here, I love to refer my patients to the local community and or senior centers. Ours is a combination family senior center. But, again, on your computers. There's YouTube channels where you can download things for free, but it is important to coordinate everything you're doing, and any questions you have, please reach out to your healthcare providers. That's really, really important. So now let's get into what the recommended diet is. So again, whether you have a healthy amount of MPOD, that pigment in your macula, we educate all our patients, young and old, what a healthy diet is. So the dark green leafy spinach, kale, Brussels sprouts, broccoli, that's where you're going to get your lutein. The peppers of color, red, orange, yellow, are great for your zeaxanthin. Berries, the darker the berry, the better. So blue and blackberries are a great source of carotenoids as well. The goji berry, which isn't around a lot and you can find it, but it's a little bit more costly. That's where it has more levels of zeaxanthin. And then omega-3s. We talked about that at standard American diet. There's omega-3s and omega-6s, and we should always have more omega-3s in our diet than omega-6s. They're both important, but 6s cause more inflammation. Remember, macular degeneration is a localized inflammation to your macula. So in our standard American diet, there's way more 6s that can inflame than 3s, and that's the problem with our standard American diet. So when we think of omega-3s, everyone jumps to, oh, fish oil. Well, it's the healthy oils in almonds, walnuts, flaxseed. So there are plant-based omega-3s as well for folks who don't like fish or have a aversion to supplements that have that in there. But this, if you take anything about diet home, the Mediterranean diet, I always tell my patients, it saves your eyes and it saves lives. It really is based on getting lower red meats, much more fruits and vegetables, and foods that have those healthy oils. Salmon is one of the great for fish omega-3, a fish-based omega-3, but everything you see here, and when you look at the blue zones in the world, those folks are eating these foods and moving their body. So we know blue zones are where it's remarkable. These folks have a healthier life and live longer than other places in the world. The one in the US is Loma Linda, California, and it's because they're active outdoors and they've embraced this diet. So it's a Mediterranean diet, again, is rich in healthy plant foods. I love red meat, but when I do have it, I make sure it's a lean red meat, and I don't have it as often as I used to. You want lower animal fats and meats, and you want those healthy oils. Avocados are a great source of that healthy fat. And hopefully you can institute seafood and fish at least twice a week. Again, I'm not a big fish eater, but I do have salmon once a week and then other seafood, just because I know that that's a healthier choice. So it's all about foods that don't cause inflammation. Remember that statistic, 95% of what we put in our body is attributable to inflammation that cause chronic disease. So again, you can see here on the left, these are all the foods that don't inflame. These, unfortunately, are the foods that, don't get me wrong, we know they're tasty, but they're going to cause a fair amount of inflammation in our system. So it's really all about choices. And I love talking with my patients about the choices and making it easy. There's no shaming, right? We all have our foods we like, and it's just what we do most of the time. We have Thanksgiving coming up, right? So we're definitely going to be indulging a bit. And I tell patients that's okay to do that because it's what you do most of the time. What are your regular habits? So I love these pictures. So this is actually the picture on the left. I actually have been fortunate enough where I go into practices. I do a lot with contact lens technologies as well. And I go into practices and teach team members and docs how to fit and strategies. And this literally, they're like, oh, Dr. Lowe, coming back and have some lunch with us. And it smelled so good, right? I smelled pizza, but this is called a taco pizza. They actually put Doritos on top of the pizza. And I'm like, oh, that smells great and looks tasty, but that's deadly, right? As opposed to, I actually asked my patient for permission to use this picture. He's very active. He's an avid golfer, and he said he comes in and this is what he eats after his round of golf. And I'm like, good for you. Look at that. Healthy vegetables, And, he uses olive oil in that. So just really, really great. There are 2 legal white powders that kill us in the US, and this is one of the 2, sugar. The other is salt. But look at our change over time in sugar consumption. I mean, this is just unbelievable. In 1908, so in the early 1900s, when we didn't have all these supermarkets with processed foods, right? The average American consumed about 5 pounds of sugar a year. When in 2012, when they looked at the statistics, now this is the average American, so some are higher. It was over 100 pounds of sugar in a year. Sugar is tasty. We like it, but it causes inflammation. So 1 teaspoon of sugar contains 4 grams. Okay, so I want you to keep that in mind when we're talking about ideal amounts of sugar. Now we're talking added sugar. So you don't add up any sugar or have to calculate in regular fruits and vegetables, right? If it's what's added to it. So the American Heart Association says no one should go over 50 grams of sugar in a day, but for women, half, 25 is ideal. For men, a little bit more, 36. I don't know why they always get more of the good stuff. That's the same with wine, right? They're like, 1 glass of wine is good, but men could have 2. So I just pour a big glass. But that's ideal. And then I just like to put these up because I don't think every day we're thinking about when we grab a Coke or a can of pop, that's 39 grams of sugar. Or Snapple, we think, oh, well, this isn't pop, it's Snapple, right? A juice free. 39 grams of sugar is what's in 1 candy bar. If my goal is ideal is 25, that one thing I just drank took me over the top. A cup of hot chocolate, 24 grams. That's a gram less than what I'm trying to, stay at. So we just don't realize, and I think it's really important. I tell my patients, just start adding it up. And I love this graphic because it's the secret sugar bombs, right? So just look at breakfast. Again, my goal ideal is 25, not to exceed 50. Look at things that we normally eat for breakfast here are bringing me to either at what my ideal is or over, right? So that's crazy. And that's just my first meal of the day. Then at lunch, these are common things that we may eat at lunch. Again, I'm adding another meal that's over or at what my ideal is. And then dinner, right? We don't even realize French dressing. Like that's the thing people don't realize. You put a little barbecue sauce on something. Look at those labels. The amount of added sugar is just unbelievable in those. And then of course, snacks and drinks are where we really can get in trouble. Even you got to look at these granola bars and be very mindful. Anything that says low fat or no fat does not taste good. So they are adding salt and sugar to it. So just be very mindful of keeping track. And it's not hard to do. It's all about reading our labels. And marketers are savvy to people starting to read labels. So you could buy one beverage, and let's say it's about 12 ounces, and it'll say, oh, only 5 grams of added sugar, but you have to look at the number of servings in that bottle. So it'll say 5 grams of sugar, but now there's 2 servings in that one bottle that you'll probably finish. So that 5 just turned into 10. So beware, because the marketing folks do try to kind of get around that and make you think something can be a little healthier than what it was. If I can take away one thing from any of my patients' diet, if you're a pop drinker, I know certain parts of the country we call it soda. Up here we call it pop. If there's one thing immediately you can take out of your diet, it would be pop. And it's not only the sugar, it's the artificial sweeteners that are in diet pop, because that's what many of us reach for. And that's going to make you crave more sugary things. And then just the chemicals that are in, you can see here that it's not good for our bones or teeth. Again, high fructose corn syrup, we know increases body fat. Not good for our cholesterol and makes us crave and more hungry. The food dyes that are in these things, are just not good. You can see that they kind of equal up to, if you put those chemicals together, that's like a formaldehyde. Who would want to drink that, right? They are tasty. They are thirst quenching, But if you can take that out of your diet, I tell, with these soda stream devices they have now, if you like bubbles, just using regular water, putting bubbles in it, and then fresh additives of lemon, lime, or natural sweeteners that you like, is great. So let's turn to sodium. So again, not more than 50 grams a day of sugar. Salt, you don't want to go over 1,500 milligrams a day. So that's the ideal. And it's not you with the salt shaker, it's in everything that we buy. Again, mindful of low fat, no fat. That's going to be the ones that are going to add more salt and sugar. The average American eats over 3,400 and we want 1,500. Just wanted to show you here, it gets very confusing with the packaging. So like sodium free is going to be your lowest amount of milligrams of sodium per serving. Very low sodiums just above that, but sounds like it would be lower than sodium free, but sodium free is the best. And again, you can see here, low sodium is going to equal approximately 140 milligrams. Then they use these other terms, light and sodium, so again, just read the packages and keep track of the amount of sodium per serving. So I tell my patients, shop the perimeter. That's where we're going to be the safest because there's not a lot of additives in all your fresh, there are no additives in your fresh produce. Your fresh baked goods are usually going to be healthier. And again, now they have nutrition labels on those. And then your fresh proteins, your meats, your fish. You want things that are fresh and not packaged. It's when we're in the center aisles where we have to be very mindful of those packages and making sure we read everything. So just to wrap up diet, I wanted to just say the healthy choices for the eyes. We talked about all the healthier foods that you see here, but I want to talk just briefly on hydration because that's important, mainly for our tear film and our quality of vision. The first optical surface light hits is our tears before it even hits the cornea, the front of the eye. And of course, for our general health, hydration is so important. So again, 13 cups for men, 9 cups for women should be minimum. So keeping track of that. You want to make sure you're having, if you have juices, that they're low in added sugar. And again, 25 grams is ideal, 36 for men, not going over that 50 grams of sugar in a day. Caffeine is good. It's the best most accessible antioxidant in the world, but we overdo it with the caffeine. So 1 to 2 servings max actually are good for your tears. But if you go over that, caffeine does dehydrate. And so that's the issue. And then it affects blood pressure, things like that. And then teas are great, but if we overheat teas, then they kind of lose their medicinal. So just be mindful of not heating those up too much. So as true Americans, right? We're like, so I was wondering, does 3 glasses of wine and 2 Bloody Marys equal 5 servings of fruits and vegetables that I know are healthy? We ask ourselves that. We always want to go to the things we love. Well, here are the healthy indulgences. Dark chocolate. If you like chocolate, try to get 70% cocoa or greater. It'll be lower in sugar and not as sugary, right? But it's definitely healthy. It has antioxidant. Cocoa has antioxidizing, anti-aging properties. Red wine, again, in moderation. Resveratrol is an enzyme, antioxidizing, anti-aging. So they say 1 glass for women, 2 glasses for men. But again, especially with a meal, you couple that with a meal, and I'll tell you those blue zones, if they are having any alcohol, it's always in moderation with a meal. So just wanted to just finish up here and then get to our questions. These are, we've heard about AREDS 2, and that's why I put this up. You hear AREDS 2 all the time. And that's a great formula, and it has its place for folks who have already had progression. But I'm in the space where I want to be proactive instead of reactive and know there's been so many studies since the last ARED in 2012 that we should be supplementing earlier on. And how great is it if we do convert, that we have all these wonderful interventions. But my job as a primary care optometrist, my job is to be the quarterback and keep my patients with good, healthy habits being seen regularly on the schedule they need to be. And I work with 5 other excellent surgeons. My ophthalmology colleagues, and retina is one of those 5. But my goal is to keep you from needing to go there. And so together as a team, we can build strategies from that. So again, wrapping this up, what can we do to improve outcomes? Timely eye exams are the #1 thing, so that those risk factors can be well identified, ones you may not even think of. And then early detection with measuring macular pigment and dark adaptation are key, because I'm catching patients well before vision loss. And of course, managing chronic conditions, that's what you do with your eye doctor and obviously your primary care physician, endocrinologists, cardiologists. Those are all so important for managing diabetes and cardiovascular disease, which puts you at higher risk for vision loss. And then we already talked about moving our body, putting good things into it every day. Those are where it starts. And then when supplements are needed, those are great to add on. If you're a smoker, quit smoking. And then, of course, your doctor, when you come in for regular comprehensive eye exams, is going to be great at telling you how to protect UV light and from the harmful blue violet light. So again, in the primary care space that I'm in as a primary care eye doctor, I want to identify your risks when your vision is normal and you're not having many symptoms. That's the most efficient time to treat. I love that train analogy that I've made reference to, but it's like this, right? You're looking the other way. You don't even know that this train is coming. And that's our job as a team, as patient doctor, to work together. So, we talked about, this is the age group of folks that generally we think to talk about macular degeneration with, but these are actually age progression pictures, which was kind of cool. My 2 sons turned me on to that. That's Trevor. He's actually 29 years old. But look at what his age progression. That's pretty wild, isn't it? And then this is my other son, Cody. He'll be 34 next month, and he was at a wedding, and look how it made him look like grandfather of the bride in that picture. And then if you haven't guessed, that's me. This was taken a couple years ago, but what my age progression looks like. I love it. Fortunately, I've been fortunate. I haven't had to dye my hair yet, but I love that they gave me still brown hair, which is nice. So just again, to end up, and we'll get to the questions. One of my favorite patients said I was okay to use this picture. She immigrated here from Italy. When you ask her what she eats, she's like, "Oh, I cook fresh." And I go, "Do you ever go out to dinner?" No. I come at home and I cook fresh. She has one of my highest scored MPODs in our practice. When we took her baseline MPOD, and she was 83 at the time, her score was 81%, which again, on the high end, because of everything that she ate. Her eyes, she was seeing great until the time she needed cataract surgery, was nervous about getting cataract surgery, but her macula was healthy. I'm like, you're going to love the new vision. And after she had cataract surgery, super happy. She still has little better than 20/20 vision, and I attribute that to her lifestyle. She moved, she doesn't do a lot of exercise, but she walks a fair amount a day and puts good things in her body. So wanted to make sure you had my email. I love whether they're patients of mine or not. We love being the trusted eye care professional in our community. So we welcome any questions. So it's my first initial last name at proeyecarecenter.com. I thought Sally O'Malley, which is a Molly Shannon character that's 50 and says she could still kick and bend and stretch. That's what we all want to be. So I'm going to stop sharing my screen now so we could take some questions. Awesome. So the first question here is, do you suggest that we take vitamins to get carotenoids? If so, which one? Great question. I always say it starts with what you eat. So I would love for you to eat those things that you can get carotenoids. We said the dark green leafies, spinach, kale, Brussels sprouts, broccoli, all those foods, berries, those are great because it starts there. But I always, if someone's higher risk, even though they may have healthy MPOD and they have a family history, so those things take to account. into count. I say whatever, you should consult with your doctor, but anything that is a healthy amount of lutein and zeaxanthin in it. And so patients will say to me sometimes, oh, well, I have a multivitamin that has that in. And I tell them to send me a picture of the label, or we look at the label, and it's a very, very low dose. So the recommendation for most doctors is you want 2 to 10 of lutein and zeaxanthin. I customize that to what I feel my patients need. So I don't like to get into the weeds of brands because there's a lot of good ones out there. So you should definitely talk to your doctor about that. And they could direct you in the right way. Another great resource is the Ocular Wellness Nutrition Society, OWNS.org. They are great at giving you information on where you could find, good quality vitamins. Can you have macular degeneration and glaucoma at the same time? If you have both, do you lose your vision totally? Great question. So glaucoma, the good news about glaucoma, in most cases, it's a very slow, insidious disease, but we call it the silent thief of sight because it slowly takes your peripheral and can lead to total vision loss. So that one alone is definitely a blinding. We know it can blind. Macular degeneration wipes out your central macula, which is so important for functioning, but at least you have peripheral and mobility vision. So the combination of the two is not a good combination to have. So unfortunately, that's why, again, timely eye care is so important. But glaucoma alone can lead to total vision loss. And then you add macular degeneration, and it's kind of a 1-2 punch. Why does it seem that there is more research being done for wet macular degeneration and not being done for dry? Actually, there's a lot of research in both. It's just dry is a harder nut to crack because of just physiologically. Dry is just like it takes tissue away. And so it's a different mechanism. Wet macular degeneration is blood vessels that grow and get wet and leaky and cause disruption of the photoreceptors and inflammation. And so those drugs came out first. It was by happenstance. They're actually called anti-VEGF. So that's what we use for cancer patients to cut off blood flow to tumors. So it's just easier to have in our armament of treatments. It was just easier, and we found the kind of the best approach for drying up those blood vessels, where geographic is actually where the tissue just leaves and is gone. But as you know now, there's an injection for geographic, and more people do go on to get wet than the dry statistically, but either is not good, right? There's so much talk about diets. Which diet do you recommend? I hope we answered that. The Mediterranean diet is really the best. You can look that up easily. Again, it's getting the healthy oils, olive oils, avocado oils, reducing red meats, and minimizing alcohol. Can optic nerve drusen migrate to a section of the eye to cause AMD? It's different mechanism. Great question. So optic nerve drusen usually comes on way earlier in life, and it is that waste product buildup right at your optic nerve. Now, the good news about functional vision with that is your optic nerve is your blind spot in your field of vision. So it can increase your blind spot, but that's a great point. There's not a direct correlation between having optic nerve drusen and macular drusen. So let me get back here. Okay. Where can find the sugar bomb graphic? Oh, you know what? I have that. If you email me, I can get you that because it's in the notes of my slides. I didn't have it. What about Coke Zero? Good point. So even if they don't have sugar, they have additives of all those dyes and other things in them that are not healthy. They can cause inflammation. And again, Coke Zero can cause you to crave more sugary things and be more hungry. Is canned vegetables okay? Some fresh vegetables are too pricey. Yes, if they're so I recommend look at the label. What are they stored in? Watch for sugar and salt. I have to tell you the fresh frozen vegetables are great because and look at the packaging because those are flash frozen with usually no additives, and because they're frozen they don't have to add a lot of other things to them, so that's great. I've read that alcohol is a big no with wet AMD. Is that true? Alcohol is a big no with any condition in our body. When you already have any form of macular degeneration, again, that's inflammation in your macula. Wet is those new blood vessels have grown. So we want to stay away from anything that could cause more inflammation. And alcohol also thins your blood. So you got to be careful with that on any condition you have. So if you're on blood thinners, things like that. Is black seed oil safe for wet AMD? I've read it's been promising for its neuroprotective and anti-inflammatory properties. Yes. So the jury's still out on that. I've read a little bit about that. So again, I would say in moderation, it probably is okay. But I don't have a lot of science that I could refer to yet, but I know there's studies going on with that. So thank you for that question. My AREDS has no zinc in it. I have another one that has zinc. Can I alternate them daily? Okay. So if you are having a healthy diet, you are going to get the amount of zinc you need. Again, zinc came from, it was part of the original AREDS 1 and AREDS 2, and we know it's an essential element we need in our body, but too much zinc is not good. Zinc depletes the copper in our system. So it's controversial with some doctors, but I talked about that genetic testing. Depending on the genes that are your high-risk macular degeneration genes, there's a camp of us that believe there was a kind of a sub-study that was analyzed off the ARED study that some folks with certain genetic factors, about 15% of folks, should not have zinc in it. So I do, on some of my patients, I tell them, don't use your eye vitamin that has zinc in it. You're going to, hopefully if you're eating healthy, our body needs zinc. You'll get the natural amount you need, but you don't want to add more on to it. So again, I tease that out through genetic testing with my patients. But again, talk to your doctor. Let me just get back here. My screen keeps going off here. How often does intermittent dry AMD progress to advanced? Intermediate, it's a smaller percent. We saw those numbers, about 20 million people have it, but 1.5 go on to the advanced form. So again, a lot depends on your lifestyle and your risk factors. So if you know your genetic roll of the dice, that's really important because these genetic tests can tell you your risk in 5 years, 10 years, 15, 20 years out, depending on, because your genes don't change, right? And so they run algorithms that take into account your lifestyle, your age, and your genetic roll of the dice, and can tell you more accurately. That's why I do like genetic testing for my high-risk patients. But, if in most cases, if you're on top of everything we talked about, you're lessening your chances of it going on. Does it matter what time of day I should take AREDS, with or without food? So I tell my patients, we get busy, right? So I tell them, try to take it at the beginning of the day, always with a little food in your stomach. Most nutritional supplements just fare better with a little food in your stomach. So, I say a little food because if you have a whole meal and then you're putting that vitamin on top, we just want to maximize your absorption rate. So I literally take mine. I'll take just a bite or two of food, and then I take my supplement. And then I know it's getting absorbed. You could eat more than after, but now it's right at the beginning of that and you get maximum absorption. How do I find a doctor with your same ideals in practicing? I've never heard of any of this from any doctor. Yeah, so first of all, primary care optometrists are usually going to be, we're more on the preventive side. I will tell you, we don't get ocular nutrition in our training. We don't get any nutrition in our training in most cases, MDs, ODs, DOs. It's not as big a part of the curriculum as it should be, unfortunately, and hopefully that is changing over time. If you go to that Ocular Wellness Nutrition Society site at owns.org. So funny. I've been a member forever, but I wasn't on the doctor locator, but go on their doctor locator and that at least will point you in the right direction. And then just look at your doctors in your local area. Just give them a call and say, hey, do you guys do recommend nutrition? And do they have these devices that can pick things up early? So should I use light bulbs on? So light's our friend, especially as time goes by. So good light, like our indoor lighting, like I said, gives you more contrast. But it's the blue violet light off of digital devices that are the ones we have to worry about. So I tell my patients, especially when we're reading, light's our friend, lights on in the room. It just creates more contrast. And the older we get with cataract changes, that's really important to have contrast. So I hope that answers that. Let's go here. Should I use light bulbs with lower spectrum numbers? Yeah. So actually, the warmer colors are better. They don't give you all that blue violet, which makes your brain thinks it's daytime. So the warmer, the more you can get to the warm light, that's better, especially in the evening. So you're not being exposed to all the blue violet light, which are the lower spectrum. So if you can go a little higher, that'd be great. My doctors haven't been helpful with nutritional advice. Yeah, I think that's more of a comment. And I apologize for that. I got to tell you, again, we weren't taught it. I just started having a passion for it because I saw how great it was with prevention. And we don't talk enough about what we put in and how we move our body either. And those are just such important things. One of the things that we ask our patients, and again, especially my young patients, but patients who are going off to college, now they're making choices themselves. So I have that discussion with them in high school. Like, hey, what do you like? You're going to be on your own, and then making those choices. Does the same hold true for the copper? I'm not quite sure what that means. My grandparent says I know more nutrition than she does. Oh, your GP, your general practitioner. I'm sorry, we use grandparent. Yes, that's, you know what? And you need to school us. I tell you, that is so true because they're just not getting it in school. Will there be a website we can watch this? Yes. And then I think Donna or Andrea can be more definitive with that. I know that's what I love about the Macular Degeneration Association. They have such great resources. These are all taped where you can watch them again. And then they have wonderful articles. So just keep with your macularhope.org. That's a great resource for you. Awesome. And I think that's all, correct?
Yes, it is. Thank you so much, Dr. Lowe. You were fantastic. What a great wealth of information and help that these people will get. We are now completed our programs for the 2024 season. I am in the process of designing the 2025. They will not be up on the website until January, February, when I have a better understanding of what I've been approved for. So please check back the website. Again, it's macularhope.org. And we are so thankful with Dr. Lowe. She is a part of the Macular Degeneration Medical Board. We just love her. She's provided a lot of great information. This past newsletter that went out, her article was in there. So if you have a chance to get it, let us know. We can send it on the website. There is a place to sign up for the newsletter. You can do that as well. It is free. There is no charge for it. Okay. All right. And Dr. Lowe was so kind. She gave you her email address. So if you have any other questions that pop into your mind, you can always reach out to her, or you can reach out to the Macular Degeneration Association as well. And thank you so much again. Have a lovely day. It was a pleasure.
Thank you. Thanks for all you do, Donna. I appreciate it.
Thank you.
Bye-bye.
Bye-bye.